بسم الله الرحمن الرحيم. Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everyone. I would like to welcome all the attendees. I am Mariam Al-Ka'bi, Neonatology Fellow at Security Force Hospital, Riyadh, Saudi Arabia. Inshallah, I will be the moderator of our activity today. First of all, I would like to thank Dr. Adnan for his great effort and Prof. Numri for his support of our activity. It is my pleasure today to introduce our speaker, Dr. Majed Alruaydi. Dr. Majed obtained his medical degree from King Saud University and finished his pediatric training program at King Saud Medical City. After that, he completed 2 years of a neonatal perinatal fellowship at National Guard Hospital, Riyadh, Saudi Arabia. Currently, Dr. Majed doing the Canadian Neonatal Perinatal Fellowship at Western University, London, Ontario, Canada. Dr. Majed also, he is the Chief Fellow and member of the Residency Training Program Committee at Western University. Today, Dr. Majed will give us talk about a neurodevelopmental follow-up of a preterm infant. Welcome, Dr. Majed. We are glad to have you with us today, and you may now start your presentation.
Bismillah ar-Rahman ar-Rahim. الصلاة والسلام على أشرف الأنبياء والمرسلين نبينا محمد وعلى آله وصحبه أجمعين. Thank you, Dr. Mariam, for this introduction, and thank you everyone for attending this talk. I appreciate the opportunity to be here and presenting in front of this great audience. I have chosen the topic of neurodevelopmental follow-up of preterm infants for 2 reasons. The first, because I think that we need to put more attention and shine more spotlight to this area, which I think is, if not equally important to the NICU course, it could be even more important for the baby's development to have a healthy life. I think that by starting this talk, we might have more efforts and have more attention to this clinic in the future. I have no conflict of interest in this topic. So over the past decades, we have noticed an improvement in the acute care of preterm infants in the NICUs all over the world. We have noticed more babies surviving even extreme preterm and extreme low gestational age neonates. And this improvement in their survival rates have resulted in noticing more babies who are surviving with neurodevelopmental morbidities. We have seen less and less severe developmental delays, but there are increasing minor or mild and moderate cerebral palsies and neurodevelopmental delays, which could be easily missed if we don't pay attention to them. Extreme preterms and very preterm babies are at higher risk of having cerebral palsy, cognitive delays, deafness, blindness, and even behavioral disorders, which we will discuss in the coming slides. So before I go further in this talk, I would like to discuss a little bit what is the difference between having this neurodevelopmental follow-up clinic versus the usual pediatric clinic or the general practitioner's clinic. So this clinic is specially designed to detect the developmental delays in these babies or the high-risk groups. Since the pediatrician's clinic or the general practitioner's clinic is often crowded and they have less time to focus on all aspects of the baby's health, so they pay attention more to the child's care and the acute medical problems for them. They don't have enough time and enough attention for these details. And as we discussed before, they can be easily missed if they are mild or moderate. So this is the the purpose of the neurodevelopmental clinic, it will have more attention for that aspect. It will help them to grow and to develop. The purpose of this clinic is early detection of disability, which enables early intervention, which is the key for these babies, and that maximizes the child's outcome, prevent the onset of complications, and also supports the parents. This diagram gives us a little bit of like broad spectrum of what we need to look for in the early screening. So we look at the main 4 domains in the top. So we have the motor domain, the cognitive, the social and behavior, and sensory. We will not discuss all the tools in this slide, but I think it's important to have this systematic approach for these babies, because I know that as the training program for pediatrics, and then later on when we go and see these babies in the clinic, we apply the developmental milestones, and we can detect delays in any of the spectrum or any of the domains and the developmental or milestones. But we need to figure out exactly what is the root cause of that delay. It's not enough to say that, okay, the baby is having a gross motor delay or fine motor delay. We need to know why the baby is having this problem. For example, if we have a baby who is, we're assessing that baby at 6 months of age, for example. And one of the main tools that we use for assessing their development is to ask, or even do it in the clinic, to drop an object on the floor and see if the baby will pay attention to it, or maybe even turn their head toward the source of the noise. Now, if I bring you 4 babies in that same clinic and drop the spoon, for example, on the floor, and none of them turn their head, all 4 of them will have delay in that development, for example. But each one of them could be due to different pathology. So for example, the first one didn't turn because they have like spasticity in the muscle. They heard the noise, they just cannot turn their head. While the second baby didn't turn their head because they have like cognitive delay. Or the third baby didn't turn their head because they couldn't hear it. So they need a hearing screen or hearing assessment. So it's important to dig into the root of the problem. And that is the purpose of this clinic. And that is what we need to assess for the babies. So before we go further, there are 3 main definitions that we need to discuss. So we have a definition of cerebral palsy, definition of neurodevelopmental delay, and development coordination disorder. So the first one is the cerebral palsy. And you see I make a highlight of the 3 keywords in this definition. So it's a group of permanent disorders that's affecting the development of movement that causes limitation of activity. So it's not like elimination completely, but it will limit their movement somehow. And it is attributed to non-progressive disturbance. So it is one injury that happened, and it caused the limitation of activity and no more progression. So it's a non-progressive disturbance that occur in the developing fetal or infant's brain. Now, this number here, per 1,000 live births, is the rate of all of the cerebral palsy of all the babies. But in the preterm babies, there can be as high as 7% of babies born at 24 to 26 weeks. And it decreases with the advancing gestational age. If we look at the cerebral palsy, we cannot just say that this baby is having like mild or moderate cerebral palsy. That would be an incomplete definition or incomplete title for the baby's diagnosis. Instead, we need to tell what is the type of cerebral palsy, which areas affecting the baby, and what is the severity of this cerebral palsy. And if we look at the type, the main type is the spastic, which makes the baby appear stiff and the muscles are tight. We have less common dyskinetic or ataxic types. And the fourth is the mixed type. So it's a combination of all of the above. For preterm babies, most commonly it is the spastic as well. Second would be the distribution. So we need to say that if it is unilateral or bilateral, we need to say which is it affecting the upper portion of the body versus the lower, or it could be like quadriplegia, so affecting all four limbs. And the third part of the definition would be the severity of the cerebral palsy, or the system to classify it would be the gross motor function classification system, so GMFCS. And the trick for this system is that it will change according to the baby's age. So for example, if a baby is having severity of level 1, for example, at 2 years of life, that doesn't mean that the baby will continue to have level 1 throughout their life. So they can present with level 1 initially, and then in the next visit, they can have level 2, or it could be even better. So at level 2, and then it goes down to level 1. Now that could be, like, you might ask a question like, how does that make sense? You just said that this is non-progressive disorder, so how come now it is changing? Now the reason for that, because even though that it is a non-progressive injury, but the way it presents would be different. So for example, if a baby, for example, 6 months old, and they cannot walk, I cannot say that they are having cerebral palsy because it's not their time to walk yet. So that would mean that they look normal now, but when it is time for them to walk, then that would be labeled as a developmental delay. So and also vice versa, having a baby who does have an injury and having developmental delay, but we did start the early intervention and there was improvement, so they might even go less, so from level 2 to level 1 and so on. So the type of the cerebral palsy and the distribution of cerebral palsy might stay the same with the baby, but the severity might change. When we go to the next topic, which is the neurodevelopmental delay, now this is different. So when we look for the definition, it is failure to achieve developmental milestone within the expected age. And this refers to significant delay in 2 or more domains. So it needs to involve at least 2 domains in order to say that this baby is having generalized neurodevelopmental delay. And these are, the domains are like language, cognition, personal, social, and motor skills. The third definition that we need to familiarize ourselves with is the developmental coordination disorder. Now, this one has been recognized as a hidden problem. This one is not, we don't hear it as often as cerebral palsy or developmental delay. This one has been frequently missed. And the reason for that is 2 things, because it needs a trained eye to detect it. And there is unfortunately no clear like definition or clear way to describe it. So it's a disorder of motor coordination that is not explainable by intellectual disability or any specific congenital or acquired neurological condition. Sometimes it can be confused with having a baby with cerebellar injury, for example. So they cannot have their balance. They look similar, but it is in the way they present would be slightly different. Unfortunately, the spectrum or this disorder would not be tested until at least 4 years of life. So it is a little bit outside of our group of patients, but it would be good to know about that it exists. Now, if we look at the risk factors for which group of babies would be having risk of having neurodevelopmental delay, it is easy to categorize them, whether it is antenatal risk factors, perinatal risk factors, or neonatal. Now, in the antenatal risk factors, if the baby did not, if the mom did not receive antenatal steroids or not receive magnesium sulfate, that would be an antenatal risk of having neurodevelopmental delay. Perinatal risk factors, such as severe or extreme prematurity, having poor APGAR scores, history of HIE or major congenital anomalies like structural brain anomalies or something like that. And then the postnatal or neonatal conditions, the most important ones including bronchopulmonary dysplasia, mainly intraventricular hemorrhage, infection of CNS and sepsis. Now, I want to take this moment to emphasize that it used to be believed that the severity or the risk of developmental delay is proportionate with the severity of IVH. For example, grade 1 IVH, they are unlikely to have developmental delay, and grade 4 IVH, they are for sure going to have developmental delay. That is not the case anymore. There are any case or any type of intraventricular hemorrhage, they are at risk of any level of cerebral palsy or neurodevelopmental delay. It is important to keep that in mind when we talk to the parents. It's important to keep that in mind when we take care of the babies, because that would always categorize them as a high-risk group, and they need to be treated as such. And after that, we have some neonatal managements that increase the risk, such as increase systemic steroids administration, and some neonatal surgeries like invasive neonatal surgeries and so on. So when we say high risk group, which babies are we talking about? So babies, babies who have neurodevelopmental risk of neurodevelopmental delay can be divided either to mild, moderate, or high risk. Low, moderate, and high risk for having neurodevelopmental delay. And there is no clear guidelines which how to categorize them or which way to treat them, but there is a general accepted consensus that babies who are at high risk of having neurodevelopmental delay need to be followed by a neonatal neurologist or a neonatologist, while the moderate risk can be followed by a pediatrician, and the low risk can be followed by a general practitioner. And the other reason why we are dividing them into low, moderate, and high risk is the frequency of their visits to the clinic. So high risk patients, which are the scope of our presentation today, would need to be followed every 4 months in the first year of life, and every 6 months after that. So for who are the babies at high risk group? So babies less than 1 kilo of birth weight, equal or less than 28 weeks of gestational age, having, as we mentioned before, IVH, BBD, or PVL, babies who needed the major surgery like diaphragmatic hernia repair, tracheoesophageal fistula repair, mechanical ventilation, prolonged mechanical ventilation, persistent hypoglycemia, and hypocalcemia. And we mentioned also before infections and if they have abnormal neurological examination at discharge. So like we mentioned, this is the schedule of the visits. So after a baby is discharged from the NICU, they need to come back to the developmental follow-up clinic at 1 week after discharge, which is the initial visit. And then after that, they can be followed like 4, 8, and 12 months. And at each one of those visits, they will be assessed each time with different tools that assess their motor skills, such as AIMS, which we will talk about in a minute, and INFANIP. And at 18 months and 24 months, they need to be assessed also for autism spectrum disorder. We said that neonatologists or neonatal neurologists need to follow these babies, but it is important to keep in mind that neonatologist doesn't actually do the treatment themselves, but they will detect the root cause of their problem and which intervention they will need the most. They also they have a team as well, including neurologists, genetists, occupational therapist, physiotherapist, and speech therapist as well. And sometimes orthopedic surgeon would be involved. So at each visit, what do we need to look for? So feeding and dietary counseling is an important part of the visit as well, because they will need to meet certain caloric intake for them to have a better neurodevelopmental outcome, and that will demonstrate in the growth monitoring. They will be assessed for any other ongoing morbidities if they have been visiting the hospital more often, going to the emergency departments, or going back to other subspecialty clinics. We need to do a full neurological assessment, develop detailed and formal developmental assessment, hearing and vision assessment as well. And all of this starts with the history, and the gold mine for the neonatologist for the history in the clinic would be the discharge summary. So taking the discharge summary seriously is important for this clinic to work. And what needs to be mentioned in this discharge summary, we need to know exactly what are the antenatal and perinatal and neonatal risk factors that we just mentioned that brought this baby to the clinic in the first place. What interventions that baby had in the NICU, how long they stayed in the NICU, and what are the types of tests that needed after the discharge. We need to have a baseline for the baby. So we need to have a baseline images of the head. We need to have a baseline medical examination for the baby, inborn screening, including the congenital hypothyroidism, and also assessment of the parent coping and developmental environment. This last point we will discuss in depth in the intervention section. Initially, they will need good caloric intake, so they can reach up to 165 kilocalorie per kilo per day for the catch-up growth, which can decrease later on. They need a good amount of protein, fats, and polyunsaturated fatty acid to be specific. And the average weight gain that we aim for is 15 to 20 grams per kilo per day. They need good amount of iron, good amount of folate, vitamin D, and calcium as well. And all of this can be assessed with if there is a nutrition specialist in the clinic as well. So as we mentioned, for the growth monitoring, there is an increasing evidence that static or dropping centiles of the head circumference is related to a neurodevelopmental delay. And in the table, we see the target for neurodevelopment for head circumference for each visit. And also to plot the weight and the length at the chart as well. For the neurological assessment, we need to assess for the 3 parts of the neurological assessment. So we have the neuromotor, the neurosensory, and the neurobehavior. For the neuromotor, we have like the general neurological examination, and then we will follow it up by specific tools that would give us a score in order to know in which direction the baby is leading us, whether toward developmental delay or toward normal development. And neurobehavior as well, such as the neonatal reflexes and the behavior at home. So the first tool that we have is the Ages and Stages questionnaire. So Ages and Stages questionnaire is a developmental screening tool that utilizes the parent-centric model. So it is easy to apply. It is available in multiple languages, and the parents can receive it before the visit, and they can fill it up. It will help the neonatologist to get a better understanding of how their baby overall is behaving at home, which is their familiar environment, unlike that 30 minutes to 1 hour in an unfamiliar environment in the clinic. And it is there are multiple studies that has proven how accurate and how much of a good value it carries, since we have a large French study that followed up to over 5,000 preterm infants using the ages and stages questionnaire up to 2 years of life. And they have found an excellent correlation between the ages and stages questionnaire and the Bailey assessment at 2 years of life. And this graph shows us, it's a busy table, but it mainly shows us if we look at the 24 and 26 weeks gestational age, we can see that they have very high score for ages and stages questionnaire with ASQ score below threshold of around half or more than half of the babies born at this gestational age did develop neurodevelopmental delay. Next tool will be the Hammersmith Infant Neurological Assessment or Examination, sorry. So this is a standardized neurological examination. It can be started like from 2 months all the way up to 2 years. And this is a standardized tool. It has about 24 points, 24 tests, which will evaluate the nerve function, the movement, the reflexes, posture, and the tone. The difference between this HINE versus the usual neurological examination is that this one will give us a score upon which we will have an idea of how well the baby is doing. So it is, as we mentioned, 24 observations, and each one we can score it according to the finding that we have. And we need to mention in the notes for each one whether it is unilateral or bilateral. So if, for example, baby can have a good arm traction for the right side, but not for the left side, or if we try the leg recoil, or if we check for the head lag. So each one of them will get points for how much head lag he's got or she's got. And if it is or for example, ventral suspension or leg traction. Now, the observations that are the two sides, then we can subtract half if it is unilateral. Now, why this HINE is important, as we mentioned, because it will give us a good indication of which direction in terms of development baby is heading. This study is done by Novak et al., which is a systematic review in 2017. This study showed an early and accurate diagnosis and early intervention of cerebral palsy. So the strong point about this exam is that if we combine it with the head imaging, whether it is an MRI or a head ultrasound, it can give us an accuracy of up to 90% to predict whether the baby will have cerebral palsy. And if we see this graph here, they will divide whether it is 5 months corrected gestation, less than 5 months, or for more than 5 months. And if, for example, the baby you're examining is less than 5 months of corrected gestational age, then you apply both the HINE and the MRI results, and you can go down and we'll be able, combining these scores and MRI results, be able to predict if the baby will have cerebral palsy or not. And that is important because if you were able to do that earlier, then you'll be able to intervene and improve the outcome. What score, the maximum score for the HINE is 78, and that is for the completely healthy baby. So the cutoff or the threshold to detect cerebral palsy is 57. Next will be the AIMS, Alberta Infant Motor Scale. Now, this is another neurological assessment for babies, and it will help us in two things. First of all, this, unlike the Hein, this one we don't even like touch the baby or examine the baby. We just see how the baby is doing on their own, and that is a major difference, because Hein will assess the baby by yourself, so you don't really test the higher cortical functions. You're just checking for the muscles themselves, if they're working or not. So mechanical kind of examination, while the AIMS will look for both a little bit of mechanical, but also a little bit of their own development and cognition. And the second thing is that this AIMS is more helpful as a research tool for assessing the efficacy of rehabilitation. So before and after applying a certain rehabilitation or intervention. And this is how it looks like. So we start with the baby as early as possible, and then each picture or each position the baby is able to do, that will add 1 point. And it is like this is a portion of it, but it is a long page. And each position the baby is able to do, then they will get a point for that. The total number will be applied on a chart here, similar to the growth chart, and it will tell you whether the baby is on the 50th percentile, 25th, or 10th, and you'll be able to follow the baby accordingly. So it will tell you more of a trend of how the baby is doing. Infinib is another tool that is also helping us. Now, each one of these tools is only adding a piece to the puzzle, and each one on its own will only be able to tell you so much, but together they will have higher value. So if you do the Hein alone, you will only get a little bit of information if you do the AIMS score. But if you have the Hein score and the AIMS percentile, then you'll have a better understanding of how the baby's overall development. Now, if you add those to the Infinib and measuring the actual angles, as we see here in the bottom, so the French angles, including the scarf sign, the heel to ear, popliteal angle, this will even tell you more understanding of the baby, how the baby is doing. So this is an assessment of the tone, again, and measuring at each age how much angle these joints should be making. And there are cutoffs here. So if the baby is not able to do like more than 70 degrees of popliteal angle at age of 5 months, then you know that there is more increasing spasticity in that area. And this is the tool that is used for measuring the angles. It is more accurate way and more objective way, which is the purpose, which is the thing that we always try to achieve. Now, I would like to take a pause from the tools and the assessment that we apply in the clinic, and take a moment to think about the mechanism of how the brain and the spinal cord develop in the first place. So, and for the normal development, during in utero life, we have babies between the ages of 28 weeks to 40 weeks. They're not born yet, they're still in utero, but between the 28 weeks to 40 weeks, their spinal cord develop, or let me go to the next graph. So the brain and the spinal cord, they have two main pathways. So we have the the cortico-spinal pathway, and we have the subcorticospinal pathway. Here on the left side of your screen, we have the corticospinal pathway. And this pathway will develop between the ages of between 40 weeks of gestation until 1 year of life. While on the right side of the screen, you will see the subcorticospinal pathway. And This one will develop earlier on, so from 28 weeks to 40 weeks. Now, why are we discussing these things? Because the corticospinal pathway, which develops later on, it develops in a cephalocaudal fashion. Cephalocaudal fashion means that the myelination of the nerves that are supplying these areas, they will develop from the top part of the body and slowly going down. So if that corticospinal pathway that is developing from birth all the way to 1 year, and that is myelinating slowly from the top part of the body to the bottom, that means that the top part of the body will become stronger first. And that is what's happening. So when the baby is born, the first thing that develops is their head control. They will be able to move their head better. They will be able to control their movement when you're holding them and so on. Then they get a little bit bigger. They recognize their hands. They start to move their hands from the right to the left. Then they get bigger. They have better core muscles movement. They start to sit without support. They get bigger. They reach 11, 12 months of life. That's when they start to standing up. They start to walking slowly. So these muscles are developing from the top to the bottom. So if the baby, so that's one pathway. The other pathway will be the subcorticospinal pathway, which is the right side of your screen. And in that pathway that's developing from 28 weeks to 40, and that develops in an opposite way. That will develop from the caudocephalic fashion. So the nerves will be myelinated in the opposite direction. The nerves in the feet will develop first and then going all the way up to the brain. And if the baby is born preterm, for example, at 29 weeks or 30 weeks, for example, then the nerves in their feet are developed better than the nerves in their head. So that's why they will be kicking their feet, moving their feet better, but they cannot move their head at all. And that's why they give you a harder time when you insert a PICC line in their feet, but their head is not just sitting there. And so this understanding this pathology or pathophysiology is a key to understanding how the baby is supposed to develop after birth when they are at risk of neurodevelopmental delay. So if the baby, for example, is born preterm and they are coming to your clinic, you know that you worry about the core muscles more and the head control more than the legs. And the intervention then will be directed for that. So you will be supporting their legs while training their upper part of the body, while training their core muscles, because you know that due to the preterm birth, which abrupted this physiological pattern, that's the result, and that is the weaker part of their body. So therefore, okay, I think this is part we discussed it. So that's from motor aspect and the gross motor and the fine motor development for the preterm babies. Now, if we look at the behavioral aspect, so we have two tools that help us with that. So one of them is the Bailey scale. So it's a widely used tool and is most sophisticated assessment for infants and toddlers. Unfortunately, it takes a long time, so it takes up to 90 minutes. It needs a very well-trained person and certified person to apply it. Sometimes the baby will not be as cooperative, so it might give you like wrong results, as we will show in the coming slide. So it requires a specialty training and it's a lengthy examination. Another examination also, or another tool that is newer now, and they're trying to show superiority to the Bailey, is the Cognitive Adaptive Test Clinical Linguistic Auditory Milestone Scale, or CAT-CLAMS. Now, the difference between these two tools is that the Bailey doesn't assess for the language function, while the cat clams will assess for both the cognition and the language for the baby. And it is another assessment that is practitioner administrated, and it's advantageous for high-risk children. The problem is that most of the studies and most of the research, they assess for the neurodevelopment in the Bailey. So we don't really know for sure how strong is that test. So neurodevelopmental outcome and very preterm and low birth weight infants. So this is a meta-analysis that was studying the cognitive delay among these babies, and it was shown up to 17% of babies born at this age, whether they are preterm or very low birth weight, they would have neurodevelopmental delay based on the Bailey, but we don't have yet clear comparison between the Bailey and the cat clams. Now moving to the hearing. The cochlea develops early, between 24 and 26 weeks, and the blink startle response develops at 26 weeks, and it becomes consistent by 27 to 28 weeks. So the fetus at 32 weeks can distinguish between the mother's voice versus other people's voice or strangers' voices. And they have been able to detect that by the changes in the heart rate and the attention, suggesting a pre-attention reaction. Why are we focusing on that? Because when the baby is born extreme preterm, they are born as early as 23 weeks. They have moved from a quiet and well-protected sound environment to the NICU, which is very loud and very disturbing their hearing development. Another thing is that they are at risk of deafness because of the ototoxic medications and sometimes the low socioeconomic status, which is related to their exposure to conversations, to words. And there have been interesting studies looking at the conversation to the babies versus their composite verbal scores. So this study done by Romeo et al. In 2018, it was looking at like babies up to 3 to 6 years of life, and they have been recording the conversational turns. And by conversational turns, we mean when the baby says something and or like blabs any different sounds or something, and then the adult will say something back to them. So that's considered one conversational turn. Or the opposite, when the parent or the adult say something and the baby or the infant will make some sound or response. So that's also count as a conversational turn. So they have noticed that this scatter plot shows us that the higher the conversational turns per hour, the more composite verbal scores they will be able to score. And they have done this test, done this study using a technology called the language environment analysis. And language environment analysis is basically a recorder that is attached to the baby, and it will record sounds within 3 meters of the baby. And they have lengthy records. I don't remember the exact number, but they've been like in thousands of hours of recordings, and they have been counting the conversational turns per hour. So, and they have found a nice correlation between conversational turns per hour versus the baby's verbal development. Another study here has taken it a step further. So not only that they've looked at the verbal outcome for the baby based on the conversational turn, but they have counted how many words was the threshold before the baby have a response in their verbal communication. And they have correlated it with the baby's cognition and Bailey at 18 months to 2 years of life. So they have noticed that with every 100 adult words, so with every extra 100 adult words, there will have been an increase of 2 points in their developmental assessment tools. So these studies, two studies, and many more in the literature strongly support the concept of implementing family integrated care in the NICU, and how conversations and talking with the babies improves their cognitive function and their speech function as well. So how do we assess for that? There are two ways. This one is called the language evaluation trivandrum, and this is a tool. If you look at the x-axis, you look at the ages in months, and in that specific age, the baby should be able to achieve all what's behind it. So for example, a baby at 9 months of age should be achieving all the points behind, like recognizing words like dada, mama, responding to own name, looks and turn head to voices or sounds. So all of the previous ones should be applied, should be achieved. And if there is a delay in one of them, then the baby needs further assessment. Now, I know that the main or the common hearing screen will be the autoacoustic emission, but for babies who are at high risk of neurodevelopmental delay, brainstem response or auditory brainstem response would be of higher value, since it will detect sensory neural hearing loss. And here we have the severity of the hearing loss. So mild will be like if they can't hear anything less than 15 decibels, and we have moderate, severe, and profound hearing loss. And it's also unilateral or bilateral. Next will be the vision. So the vision assessment, also we know about the assessment of the retinopathy of prematurity, which is up to 44 weeks, or until the retinal vessels have all matured and all the retina has been covered. But yet the vision needs to continue to be assessed even after that, because ROP is not the only risk for preterm babies. They are also at risk of having like squint anomalies or cortical or central visual anomalies, and they need to be well monitored and have a high sense of detection for it. And in the MRI, this is again where the neuroimaging role is important here. So findings in the periorbital or parieto occipital area will be at risk of having visual anomalies, or even in the optic chiasm in the MRI will raise a suspicion for that. And you will have a team like of the ophthalmologist, optometrist, and so on. So how do we ask for it? So if there is like, if they're able, do you think your child is able to see well? That question alone will open up a great deal of answers. So the mom or the parents can like tell you that they don't know why or how, but they feel that the child can't see well, and that's enough for you to seek further assessment. You don't need more tests to confirm that. If the child holds object close, trying to when they play with them, if the eye's movement is abnormal, or the eye appearance is unusual. So every baby has a different schedule of development. There is not a predictor of intelligence. So if they are having their developmental delay, doesn't mean they're intelligent or is defected. And how long do we use the corrected gestational age? It can be up to 2 to 3 years. That's in the literature. Most of it is 2 to 3 years. So this also is another tool for assessing development, which is a development observation card. Now we're working on applying this and many tools to translate them to Arabic to be able to use it in Saudi Arabia. And this one and apply it in the hospital. So this one is called developmental observation card. It will help the parents to know if their child is going within normal, or if they're having delay, because there is a great sense that they would feel their child is delayed, but actually it's normal for age, or vice versa. They think it's normal, but actually it's delay. So this is an easy tool that the parents can utilize. Now, I know that you all know the milestones of development, so I don't need to go in them in details, but I will discuss the red flags of normal infant development. Now, when we look at the developmental milestones, they are all how they came up with them, or how did they develop them into that table. They've been using a sigmoid shaped curve, where they look at the 50th percentile, where 50% of babies have been able to achieve that specific task by that age. Then they would put it in the developmental milestone table. Now, if you now when you remember the sigmoid shaped curve, that means that at some point it's going to start to plateau, and that plateau is when you don't, if the child doesn't reach that specific milestone by that age, then it is unlikely that they will achieve it afterwards. And that age is when they develop the red flags of normal infant development. So for the example, for the gross motor, if that baby doesn't achieve head control by 6 months, then by sigmoid curve, that's unlikely that they'll develop it after that. And this is why they need further assessment and further details. Now we go into behavioral disorders. So autism spectrum disorder is a disorder of social, communication, and cognitive skills that arises in the first few years of life. Risk of positive screening was 25%. An infant with birth weight of less than 1.5 kilos. Now, this is important to take with a grain of salt, because the risk of having positive autism spectrum disorder in preterm baby can be like two-edged sword. So you need to detect them early, but in the same time, we need to keep in mind that literature has suggested that 40% of babies who are screened positive for autism spectrum disorder have coexisting other disabilities, like severe motor or visual or cognitive impairment. So just because they check the boxes in the autism spectrum doesn't mean that they for sure have autism, because we need to keep in mind that they have other coexisting disabilities. Now, there are two tools that we use for the autism. We have the MChat and we have the QChat. Now, the MChat is 20 questions that applied at 18 months and then again at 24 months. And they are yes or no questions. And there is a score. If you reach that result, then the baby is likely to be autism and need to be referred for higher center. While the QChat is different. It is 10 questions, not 20. It applied one time, no need for two applications. And it's not a yes or no question. It's more of spectrum. So always, usually, sometimes, rarely, never. So that raises two main things between like when we compare the two tools. That raises that makes the MChat makes the MChat more specific, because then you'll be able to detect the babies, and you'll be able to follow them up as well. And the QChat will become more sensitive, because if it is negative, then you don't need to worry about it. But if it is positive, then you don't know if it is truly positive or not, because you need then to follow them up. So the problem associated with the high-risk infants is that when they come very late, little can be done. So our job here is to detect them early to be able to apply the intervention. So what are the interventions that can be applied? So For the motor impairment, we can start with physiotherapy, and if not improving, then some medications like muscle relaxants or botulinum toxins. Some casts also have been suggested to help. Physiotherapy and occupational therapy are the most important thing. And I think that it's important to differentiate between the two. So they sound the same. Most of the physiotherapists are also occupational therapists. So, but how do we differentiate between the two? We look at what's their target better. So for physiotherapy, they focus on the movement itself. Can you extend and flex your arm? Can you stand up and get down? Can you do the mechanical movement and achieve that muscular elasticity? While as occupational therapy is different. Occupational therapy, they try to formulate these movements into a purposeful movement. So to do something that has a purpose. And they overlap most of the times. While the physiotherapists look at the gross motor skills, like walking and sitting and standing up, the occupational therapist will look for the fine motor skills, like holding a spoon or combing your hair and so on. For plasticity and learning. So the brain damage happens, and we always tell the parents that nothing can be done. There is injury that happened to the brain, but the truth is, neonates and babies in general, they have a very strong ability to adapt. So the brain damage changes neurons, synapses, and neuronal networks, and therefore can alter the future learning process. And that's called plasticity. And regardless of how the brain was injured in the first place, all infants' brains constantly remodel their neural circuitry to encode new experience and develop. And that is the core concept of early intervention and rehabilitation. So just for the sake of time, we're gonna skip to the main interventions. So there are three key drivers for plasticity and learning. So we have training-based intervention, we have environment enrichment, and we have parent-child interaction. So by training-based, excuse me. By training-based intervention, we have something called the bimanual training. So it's a task that is given to the child to do or to learn with both hands. Such as, for example, they give them a jar or with the screw, and then to learn how to open it with both hands. Or how to carry the ball like from one place to another and put it in the right spot. So using something that needs both hands to learn. And then there is, on the opposite, there is something that requires only one hand, which is like more of a constraint therapy. Now, cognitive orientation to occupational performance, or co-op. Now, co-op is something different. Co-op would be something that they would need to visualize or something that would need like multiple steps in order to achieve. For example, like riding a bicycle. So when the baby will need to ride a bicycle, they will need to put one foot on the ground. They will move their foot to the other side. They put it on the pedal. They hold their hands. They look around. So they push with the one foot. The circulating movement. All of this is called cognitive orientation because the things that we take for granted, we just do it spontaneously. They need thinking, and the brain actually goes through different steps to do them. And they don't have that. So trying to teach them how to do these steps will be the key for to enhance their development. Goals, activity, motor, enrichment. For example, it's an intervention that is combination of task-specific training to reach a goal. For that goal is usually set by the parents. Like, for example, being able to sit on their own, or parents helping the child to hold a book and to look at the pictures. So these things would stimulate the baby to their brain to develop more, and to achieve like certain goals in the future. For environmental enrichment, now environment enrichment will be divided into things that we can do in the NICU versus post NICU or post discharge. So we're not going to go into deep into the NICU based because this is outside of our scope, but just to have a look at it, like mainly. And by the way, all these interventions are evidence proven. All the interventions that are not evidence or not good evidence behind it, they are not included in this study, like hydrotherapy or hippotherapy, electrical stimulation. All these things are not included in the slides, only the evidence-proven interventions. So here we have mainly the lid cap and the kangaroo care and the swaddling, and the parent-administered physical therapy. And in the NICU, they are a strong environment enrichment tools for the parents to develop their child's development in the NICU. Now, after the NICU discharge, there is mainly that I want to pay attention to is the early childhood education. So early childhood education is like going to the nursery or something that's before kindergarten. So it is a system, it's an educational system from 0 up to 8 years, but mainly it is 0 to 3 years. And this is like the nursery, but it is helping. It's not just to keep the babies in one place, but also they put a specific learning objectives in the curriculum of the infants and toddlers to help them stimulate their imagination, stimulate their cognitive function, stimulate problem solving, stimulate their social interactions with the other children. This has different names in every country. In the US and Canada, they call it Head Start. In other countries, they have different names, but it is the same concept of having a set curriculum for the children to have like more stimulating tasks physically, socially, and emotionally. And the other source, this mainly for the parents. So this is called the Triple P, this is a place that called Positive Parenting Program, and it's most effective for the parents themselves to learn how to cope with the child who's being discharged from the NICU. It will help them understand their child's needs and how to develop their child better through different tasks. And there is a feedback system also. There is interactions with other physiotherapists. There are the groups to meet with other parents as well, whether virtually or physically. So being around other parents who have the same or similar experience in the NICU and also have a baby who needs more encouragement in their development also supports the parents, which in turn will help the child to improve better. So this is what is happening now. These are the tools that are that can be applied now. But what about the future? So meta-analysis has demonstrated that stem cells treatment for people with cerebral palsy has produced improvement in their gross motor skills and overall development plus rehabilitation rather than rehabilitation alone. There are many studies that have already been published. There are many studies that are right now in the making. But still there is a long way to go in terms of safety, in terms of route, how to insert the stem cells, for how long, what is the dose, what are your target group, all these questions yet to be answered, but the overall impression is that this is very promising route. And the concept of it is that giving the baby stem cells, which will be injected into the central nervous system, and it will go to the areas where the injury has happened, where there are dead brain cells, and to replace them. And they can differentiate into like astrocytes or oligodendrocytes, and start taking the role in that place, and they can multiply more and more. We're still waiting for more recommendations on how these interventions can start to be standard of therapy. So overall, in summary, or a take-home message, so identifying the high-risk group is the key, or is the start to treat them, and to start early, or stimulation or intervention. Having these plan or mind map in your mind, in your clinic, is important to go over them systematically, not just picking up developmental delay, but why the baby is having developmental delay. What is the pathophysiology behind it? Which organ is affected? Is it motor? Is it behavioral? Is it sensory? Is it poor environmental support, or poor environment enrichment, or poor or need any other supportive systems required? So these are the things important, because then it will guide you what intervention you need to be doing. Not all of these interventions that you mentioned need to be done. It's only the ones that the baby mainly require. The last point that I want to mention before I finish my talk is to recognize the parents coping. If we don't look for it, we will not see it. There are lots of parents, lots of families that may look strong on the outside, but they are having a lot of stressors, a lot of emotional stress, a lot of difficulty coping. Our job as neonatologists, not just to look at the baby, what's the development, what's the intervention, and just to end it there, but also to support the parent, look after the parents as well, and try to help them coping as much as we can. Having a family-centered care has been proven without a doubt that this is the core cornerstone of having a well-developing child. And losing that opportunity, losing that, then no enough interventions in the world would help. As many interventions as we provide for the baby, if there is no parents coping with stress, then we can't treat that child fully and to reach their maximum potential. I hope that talk was beneficial for you, and I thank you for listening, and I'm happy to hear any questions or comments.
Thank you, Dr. Majed, for your informative presentation. It was very helpful for us. For the audience, please, for any question, you can write it in the question and answer section, or you may raise your hand to speak. We have one question here. The first question, Who will follow those patients, pediatrician or neonatologist, and for how long?
That's a good question. So deciding who will follow the baby depends on what the level of risk the baby is on. If you think your baby is at high risk, which has been discussed by the definition of what is high risk or what are the high risk criteria, then a neonatologist need to follow these babies in a separate clinic, in a separate neurodevelopmental follow-up clinic. However, if the baby is at a moderate or low risk, then pediatrician can follow instead. In terms of how long to follow these babies, the consensus have been up to 3 years. I haven't seen any clinics that follow up neurodevelopmentally more than 3 years. Some of them would stop at 2, but most of the clinics would stop at 3 years. And after that, either they can be discharged to the pediatrician or to direct them to continue following with a pediatric neurologist.
Thank you, Dr. Majed. Second question from Dr. Muhammad. What is the most aspect of following preterm?
What is the most?
Yeah, what is the most aspects of following preterm? From Dr. Muhammad.
I don't understand the aspect. If you can elaborate for me more, or if Muhammad can tell us
maybe
what he
the
means.
things, I think maybe the things we will follow.
Okay.
As I understand, maybe.
So what to look for when you see the baby in the clinic? So we look for first of all, we look for the baby's overall growth. So how is the baby growing? How has the baby been doing in terms of so first the growth for the head circumference, the weight, and the length. If they are growing or they're having failure to thrive, and also to look for their comorbidities. So if they are having any other subspecialties they are following with, or if they are on any medications, or the general overall medical condition. And then after that, we go over the development as in the milestone. So developmental milestone is your introduction to pick up. First of all, you want to know if the baby is developing well or not. So if you apply the developmental milestone, and then you see that, for example, maybe at this age is not meeting their gross motor targets or potential, or they're not reaching their fine motor potential, or they're not reaching their cognitive potential, then you need to know why is that happening. Why is the baby is not meeting their potential? And then to dig deeper using the other tools that we have discussed to know whether it is because of development in the muscle, like mechanical issue, or is it development in the cortex, the cognitive issue, or is it a sensory delay, the problem in the vision or the hearing. And once you recognize that cause, then you'll be able to find out your intervention that the baby will benefit from.
We have another question from Dr. Safa about the need of cranial ultrasound or brain MRI. After how long from the discharge?
That's a great question. So following up babies. So once you have a baby who has been discharged because of prematurity, so that's the reason why they're coming into your clinic, because they were premature, and now they have already done their brain imaging in the NICU. So whether it is an ultrasound or a brain MRI, after that, unlikely that you will need the new brain images, because it won't be as helpful in terms of your management. You already know that what hit or what injury the brain took. You just are dealing with the consequences. You're dealing with the after effect. So it is rare to require brain imaging after or during your follow-up clinics. There are some exceptions. If you think there's a new insult that happened and the baby's life after discharge, or if you think that there is more a brain lesion that was not detected previously and you want to see it. But if you already have images which satisfy your questions, then unlikely to need a new one.
Thank you, doctors. We have one more question from Dr. Abdullah. Which criteria or tools to assign preterm baby as high, moderate, or low risk for follow-up?
Great. So for high risk patients, I'm gonna put it back because I think it's important to keep in mind, and feel free to take a picture of it. So babies, so this is the high risk group. This was the focus of our talk. So babies less than 1 kilo, less than 28 weeks of gestation. That in itself is high risk. So it's not cumulative. It's not like you need 2 or more on this list. Any one in this list is enough to categorize the baby as high risk for neurodevelopmental delay. Major morbidity like bronchopulmonary dysplasia, IVH or something, having perinatal asphyxia or HIE, surgical condition like diaphragmatic hernia, tracheoesophageal fistula, major cardiac surgery also should be in the list. Small for gestational age, mechanical ventilation for more than 24 hours, I think is a little bit extreme. But they did mention it in the literature. Persistent prolonged hypoglycemia and hypocalcemia. Unfortunately, they didn't say for how long is the definition of prolonged hypoglycemia. It still goes back to your decision making. Baby who have seizures is high risk, meningitis, shock that requires inotropes, twin transfusion, major brain malformation, neonatal bilirubin encephalopathy, or any baby who had hyperbiliary that required exchange, inborn error of metabolism, or abnormal neurological examination. So just the fact that nothing else is there, just you have a baby with abnormal neurological examination is enough to put at high risk. And now, if you look at the moderate risk, so it would be like 28 to 32 weeks, the weight between 1 kilo to 1,500 grams. And the low risk would be even more mature babies.
Thank you very much, Dr. Majed. Now, no more questions. I really appreciate your presentation. Thank you for your time and effort to give us this talk. Thank you very much.
Thank you. I'm happy for this, and I hope that it was useful for everyone. Thank you for having me.
شكرا جزيلا دكتور ماجد. Thank you very much. Thank you.